Thank you, Dr. Kurla. Our next speaker is Dr. Richard Saitz. Dr. Saitz is a professor of, at the medical school as well as at the School of Public Health. He is also the chair of the Department of Community Health Sciences in the School of Public Health, and he was one of the early founders of the CARE unit. Dr. Saitz will be talking about research on integrating addiction and medical care at BMC, the first 25 years.
Thanks, Chris. I realized in putting this together that I really have stuck to the title here, Research on Integrating Addiction and Medical Care at BMC, which means that there's a lot of addiction research that's been going on in the last 25 years and expanding in the last 10 to 15 years that isn't about integrating addiction and medical care. And as I was adding slides, when I had to submit the talk to Helia a few days before, I just had to stop adding slides. So I apologize to any of those of you who are not in this presentation, but it's because there was a need to focus. There's so much going on. And I can do this, yeah. There we go. But it's been going on for a while. At least since 1953, if not before that, at Boston City Hospital, when Victor and Adams very carefully characterized the alcohol withdrawal syndrome, its time course, and actually confirmed that it was due to alcohol, probably, and not due to vitamin deficiencies, which is what was thought potentially at the time. So it's been going on here for a long time. I'm going to mention a few topics: screening and brief intervention, treatment of alcohol and drug use disorder in medical settings, HIV, opioids, and then briefly Boston Medical Center's role in terminology. So we started studying screening quite some time ago. It's just the entry into getting people recognized and getting them care. And appropriately, I think, for our own medical center, we wanted to make such tools culturally appropriate and appropriate in terms of language and understanding, and validated tools to that effect. This was with support from the Center for Substance Abuse Prevention that Jeffrey mentioned, a faculty development program early on. That was 1999. You'll see the years at the top right if you want to follow some of the chronology. And then around the mid-2000s, the National Institute on Alcohol Abuse and Alcoholism came out with a single item question, and they recommended using that screening question to identify people with unhealthy alcohol use. We thought, since it came out of NIAAA, that it would be a really good idea if it was actually validated by research. And they disseminated it first before validating it, but we decided to come up and help them with that, and they supplemented a grant that we had to validate this item. And it was valid. It was an accurate tool, and it's now this was done by a fellow in general medicine, Peter Smith, and as his fellows project, and it's now the question that's recommended by NIAAA to screen people for unhealthy alcohol use. And in that same study, we validated a single question screening test for drug use in primary care, and that is the question that's now recommended by the National Institute on Drug Abuse for screening in primary care settings for drugs. Care integration. So after screening, you have to do something. You have to address whatever you find. And the first thing that's done, especially from a preventive perspective, but maybe to get as just a first step, is brief intervention or brief advice or brief counseling. And again, with CSAP faculty development program funds, we trained community-based clinicians. Now, the reason that I show this with a Senate bill on there is that this was probably one of the papers we published that got the most attention ever, and it was published in a relatively obscure journal, and it was a training project, for all of those of you who do educational evaluation, this was a before-after study of training, where we found that when we trained people, they learned what we taught them and their attitudes improved. And this study was cited, and maybe this goes to dissemination and translation as well. You just don't know what's going to be picked up. Joe Biden picked this up, and he put this in Senate Bill 1966. Unfortunately, the bill was not passed, but it says over there, Boston University Medical School researchers designed and blah, blah, blah. So we were very happy that it was at least disseminated that far. we realized quickly that having validated tools and being able to train clinicians wasn't enough to get screening and brief intervention into practice, so we designed a systems intervention to address problems in primary care and found that if we prompted physicians with those screening results and gave them specific recommendations for action, that we could increase the discussions that they had with patients, and their patients actually who had those discussions reduced their alcohol use over a 6-month period. Now, this was before electronic records, and it's being rediscovered now with prompting and decision support in medical records. This piece was done by the Bernsteins. I don't know if Ed is still in the room. Judith and Ed Bernstein. It was a landmark study of screening and brief intervention for drug use in an urgent care center, and it found that brief intervention was efficacious for reducing actually cocaine and heroin use by small absolute percentage points, and so it suggested that we could do something in general health settings to reduce drug use, although on subsequent studies in primary care, we found, and so did Peter Royburn in Seattle, Michael Bogenschutz in a multi-site randomized trial in emergency departments, and about 5 or 6 other studies in different health settings have found really null effects, that is, the lack of efficacy for brief intervention for drug use. And that's probably because drug use is a harder needle to move. People have already decided that they're doing a behavior that's not socially sanctioned. And by the way, these are not folks who have drug use disorder largely. These are folks who are using what Nora earlier called misuse. That is, they haven't quite gone on to have a disease. They have a risk factor. And so it's a little bit harder to move with brief counseling in primary care settings. And NIH, in the names of Ralph Hinkson at NIAAA and Wilson Compton at NIDA, suggested that we better go back to the drawing board on this one. But as is suggested here on this slide, and I thank Abby Kim, if she's in the room, for helping me prepare these slides, one of our MPH students and research assistants, we decided not to throw the baby out with the bathwater, and there have been some promising pieces coming out of screening and brief intervention. This was in the case of people with alcohol use disorder in the hospital, a place where if you are recognized as using substances or having substance use disorder, often nothing is done about it. So even when it's recognized, treatment isn't usually started. That's not the norm with other medical conditions, but it is the norm with substance use disorders, alcohol and other drugs. In this study that we published in Annals of Internal Medicine in 2007, we found no effect overall, and as you know, anybody who's published in Annals of Internal Medicine knows you're not allowed to publish subgroup findings and much in the way of secondary or exploratory analyses. So in 2009, we, in a different journal, published those findings and found that women, younger adults, and those with milder disorders were actually more likely to have it, were able to have a response, that is, that there was efficacy in those subgroups to brief intervention for unhealthy alcohol use in hospitalized patients. But it's not quite enough, since it didn't address most patients with unhealthy alcohol use in the hospital. So we've followed that up, and now we have an ongoing trial addressing alcohol use disorder in the hospital. It's a comparative effectiveness study comparing injectable to oral naltrexone and looking at both consumption as well as healthcare utilization outcomes. This has informed our thinking about how we might address opioid use disorder. And in case, is there anyone here from NCATS? Anyone? Anyone? Yeah, so in case there's anyone here from NCATS, we're planning to follow this up right now with an optional function in our U54 renewal and a U01 proposal this summer, because we think that we have a lot to share across the country with how to get people started on treatment for opioid use disorder in hospitals. And the reason why that requires entire proposals is that it's not as simple as just writing a prescription. There are a lot of details in terms of implementation and the health services that you need to line up in order to be able to do that. That's why it's not happening nationwide, and it's going to take a lot of focus to try to figure that out. I should say on that, just on that slide, that there are other pharmacotherapy researchers at the institution in psychiatry, Eric Devine and others, and at the VA as well. And again, I did restrict to our title of integrating care, which is a step beyond efficacy usually, right? So further on care integration, now focusing a little bit more on disorder and implementation and services in medical settings. One bit of information describing who is in our primary care settings came from Jeffrey Samet and Pat O'Connor looked in primary care to see who was there and found that when they identified people with unhealthy substance use in primary care settings, most of them were actually already in recovery or working towards that, trying to remain abstinent or having cut back. So that means that not only do we need to be prepared in medical settings to address people with acute problems like overdose or immediately post-overdose, but also to manage people over time. And so he and other colleagues, Peter Friedman, now in Western Mass, developed this approach to managing people in primary care settings who are recovering from alcohol and other drug problems to prevent them from relapse. And you have to remember that at the time, and actually still a little bit now, a lot of addiction treatment is acute. People go in and they get quote unquote 28 days worth and then they graduate. And the idea that this is a long-term issue for some people was a little bit foreign at the time and is now just finally gaining a bit of traction. I'm going to skip this one. So thinking that primary care might be a good place to do this, but not having a lot of addictions care going on in primary care, we looked at whether we could just link people from detox to primary care settings to get treatment. And that was because most people who went through detox got nothing further beyond that. And one option would be to get them into the general health care system and address addiction there. So we did find in a randomized trial that randomly assigning people to be linked got them linked to primary care, and we did that from a detox setting. And getting that primary care was actually associated with a lower odds of drug use or heavy alcohol use, that is, alcohol to intoxication. But we also recognize that there are other things that come along with addiction, and you heard about this morning as well, that pain is a common concomitant. And not only is it common and needs to be addressed, it probably needs to be addressed in part, not only because it should be, because it's uncomfortable, but because it's associated with increased odds of use of substance, and therefore people have trouble remaining abstinent because they need something to address their pain. So then we thought, well, maybe we ought to not only treat addiction sort of as a standalone condition, but do it in context, and do what our psychiatric colleagues were doing as they developed depression care management in primary care. So we did that chronic care management for alcohol and other drug dependence in primary care. This was a null study, showed no efficacy of chronic care management for dependence on alcohol or other drugs, showed no difference in a wide range of outcomes, primary and secondary outcomes. They did allow us to report lots of subgroup analyses in which we found no efficacy, and it was quite disappointing. However, again, baby bathwater. It doesn't mean that we shouldn't care for this in primary care as a chronic issue. We looked carefully at those who had received high-quality chronic disease management. You can measure that with research scales. And those who did seem to have improved addiction outcomes. And then we thought, well, when you do care management for other conditions, you know, you don't do chronic care management for every single person with asthma, David, right? Not every single person. You do it with those who particularly need it and are well suited for it. And if you think about this in terms of addiction, it may explain why our general approach to doing chronic care management for everyone unselected didn't find efficacy, but where we've found substantial success in taking care of patients with specific condition who are ready for treatment, like opioid use disorder with opioid agonist treatment. And these are papers by Dan Alford and Colleen LaBelle and colleagues. Look, even Michael Botticelli's on there. He escaped, I guess. And the one on the left was a clinical experience of providing that collaborative care for those patients, finding successful treatment in half. Actually, that's about the number that Nora cited earlier today. And and those who remained in treatment doing really quite well. And then Colleen LaBelle in the front row, who will speak a little bit later, has had a central role in not only implementing this here, but disseminating it statewide by using a collaborative care model that's focused on, with a central role for nurses, because doctors really can't do this in the brief period of time that they have, and it really does take a team focused around a nurse as one model to be able to do this. But it hasn't been so successful for youth yet, and you saw lots of slides already. This is just one other data point, this one by Scott Hadland, showing that while buprenorphine and naltrexone among youth is increasing as a treatment, it's still not nearly as common as it should be, and we heard about this from Sarah Bagley in particular earlier this morning. Now, I mentioned earlier treating alcohol use disorder in the hospital and suggesting that it has some relevance to treating opioid use disorder. And sometimes when you've been in the addiction field for 25 years, like I have, it feels like it's back to the future again. So I can go back to the 2000s. Chris Shanahan, who's sitting here in the second row and our host for today, published this piece on the transitional opioid program. This was getting a nurse care manager type in the hospital to take care of people, basically identify people in the hospital with opioid use disorder and begin offering treatment, starting it in the hospital. I mean, it boggles the mind that this would be a novel concept even then. It's still a novel concept now, but it was happening here at Boston Medical Center, although it did rely on one person. And when that one person was no longer in the job, the activity no longer happened and patients didn't get treatment. That's changed now as Alex Wally and colleagues, and now directed by Zoe Weinstein, developed an addiction consultation service. And one of the main services provided, or one of the big differences I think that service has made, is by identifying people who could receive medication for their addiction and starting it in the hospital and then continuing it. And that's what was published here. It was, I believe, one of the first consult services of its type in the country, published now in 2017. Just a quick word about HIV. We haven't forgotten about it. I'm not going to tell a big story about it, but we just know that substance use and HIV overlap quite a bit. And this was a piece back in 2007 where we found that heavy alcohol use affects HIV disease progression in those who are not on antiretroviral therapy. That is, this wasn't an effect of alcohol on your ability to take your medication. It was an effect on something else. And that there are other factors in patients with HIV infection that affect their long-term course, even their mortality, including drug use, recent heroin and cocaine use, as well as social factors like homelessness. And then we've gone internationally as well. This paper led by Alex Wally, looking at risk factors for overdose. The risk factor they found was more frequent injection, but really the biggest observation, I think, was that non-fatal overdose was common, very, very common there in a population of people with HIV infection and injection drug use. Almost lastly, just on opioids, when I should have mentioned, well, no, I won't say what I should have mentioned. Okay, so on opioids, Alex Wally's work again on opioid overdose rates, finding that death rates were reduced in communities where naloxone education and distribution were implemented. So this is actually involving community-based contacts and implementation out where it's not so easy to do. That was in the BMJ in 2013. This harkens back to Mark LaRochelle's presentation earlier this morning, finding that after non-fatal overdose, opioids were dispensed to 91% of patients. After a non-fatal overdose, a visit that they, sometimes I feel like I have to say that again, right? Like, people had a non-fatal overdose, then they went to their doctor, and then they got opioids. So anyway, and there was a substantial risk of patients having a repeated overdose. So, and then, not just to leave it to observations and observational data, Jane Liebschutz published this piece last year on work done in community health centers on improving adherence to opioid therapy under guidelines, trying to get safe safer prescribing into practice. And in that cluster randomized controlled trial, they basically found that they improved some of the measures of care, like urine drug testing, and whether there was a signed agreement in the chart about how their care would be managed. So that's integrating care here at Boston Medical Center and related community health centers. Lastly, and it may seem unrelated, but I do want to just make a couple of comments about terminology. And I've found that I've been a little bit more successful getting people to use correct terminology, especially in scientific groups when I argue for accuracy more. And I know the argument this morning has been largely about stigma. We'd like to reduce stigma, and I'm totally on board. I want to reduce stigma. But there's often argument about what's the right word and what's more stigmatizing and less. So I find going the accuracy approach is helpful. And there was one word that we were able to get international agreement at the International Society of Addiction Journal Editors. They agreed on a statement, and this is translated to other languages too. So it's not just English, and that was the word abuse. And the reason for that is I'll start with it's completely inaccurate. If I say, just think about this for a second, he was abusing cocaine. And then I say, he was using cocaine. What's the difference? Can somebody tell me the difference? I don't know what you mean. If you think there's a difference, I don't know what you mean. What we know, the observed behavior was the person was using cocaine. I don't know how you abuse, maybe you hit it with a hammer or something, or I'm not sure what you do. So use, describe use. If you want to describe use with a consequence, then let's use a clinical term. Like in the rest of medicine, we use like myocardial infarction we use that term and everybody knows what it means. So let's use substance use disorder if that's what the person has. They have use with recurrent consequences. And Boston Medical Center has been at the forefront with its Words Matter campaign, getting all of our faculty, staff, students all to sign that we're going to try to use less or non-stigmatizing language, and I'd argue more accurate language. And because I'm standing up here and because this was about opioid use disorder a lot today, I'll mention the other one that folks have found stigmatizing, and you may be surprised, and that's medication-assisted treatment. You could say, well, how could that be stigmatizing? That's the thing we're trying to get everybody to do, is take medication-assisted treatment. Have you had your medication-assisted treatment of your cancer? Have you had your medication-assisted treatment of your diabetes? If you did, it would sound like, oh, well, for diabetes, you can get like real treatment and then maybe some medication-assisted treatment. No, and diabetes is treated by behavioral treatments and medications, right? So here's what we do in the rest of medicine, and I'll leave you with this, is let's just call it medication or medication treatment, or medication for addiction treatment if you're really tied to MAT, right? Medication for addiction treatment. It's just medication, and it treats the disorder. That's all I got. Thanks.
Thank you, Rich. We're running a little behind, but it's hard to believe that somebody wouldn't have a question for this guy. So if there's any questions?
Has their terminology made an impact yet?
So has the terminology made an impact? That's a really good question. The answer is we don't know. We don't know that. We do know that the study that Michael Botticelli was talking about earlier today was done by John Kelly at Mass General, and he found that in a vignette, if he used the word abuse or used disorder, that people were more likely to choose punitive treatments rather than treatments. And these were experienced mental health and addiction clinicians if the vignette described the person as an abuser or someone with abuse. But we don't. And you know, ecologically, things are happening where we're seeing more treatments being accepted in medical care. We're seeing addiction being treated more often in medical care settings. Is that partly because of the language we use? I don't know, but I speculate that it has something to do with it. How we look at this problem in society is reflected in how we talk about it. How we talk about it is reflected in how we make policy. So that's my speculation, but we don't have evidence of it yet.